Dear colleagues, thank you for accepting my presentation in this meeting. As everybody knows, endoscopy is the gold standard for management of patients with caustic injuries and selecting them for surgery. In a recent publication, our group studied the computed tomography to evaluate transmural necrosis after corrosive injection in patients with high-grade endoscopic injuries. We have actually defined three signs of radiological necrosis, of which retrospectively only one is enough. Now with more than 300 CT scans for caustic injuries, I can tell you that the absence of post-contrast wall esophageal enhancement is enough. By using CT to select patients for esophagectomy, we showed that there was a survival improvement when compared to patients selected by endoscopy alone. We had better functional success rates, and we had no wait-and-see mortality, and we were able to preserve the esophagus in 1/3 of the patients. Why we did look at the esophagus is because that's the critical point in after caustic ingestion. Because if you have a doubt on the stomach, it's easy. You perform laparotomy, you go and look, and if that's not necrosed, you don't resect. But you cannot do this for the esophagus. But while doing it for the esophagus, of course, we just looked at the CT scans of the patients, and we looked at the stomach also. And if you take post-contrast enhancement of the gastric wall as a sign to evaluate necrosis, you have the following situations. You have situations like this where you see the esophagus and the stomach are quite normal. You have this kind of situation when there's gastric wall edema and you have contrast in the stomach. And you have this kind of situation where there is no contrast, no enhancement of the gastric wall, which is probably a sign of gastric necrosis. So the next question was quite logical. Can we just manage all patients with a CT scan? So for the next 18 months, we took the consecutive 120 patients which were seen for caustic ingestion, and we performed both endoscopy and CT. When the findings were concordant, we did what the exams told us to do. So we operated 24 patients. We performed conservative management in 77. And when findings were discordant, we decided to wait. What's interesting is that there were always unidirectional, so there was no case where CT shows necrosis and endoscopy low-grade injuries. They were always in the other direction. When we regarded the results of the pathological study of the operative specimen, 16 patients actually underwent organ resection. We had 9 necrosis confirmed for the esophagus, and all 16 patients who underwent gastrectomy had transmural gastric necrosis. But what's interesting is that when you see the performance of CT scan versus endoscopy, both for the esophagus and for the stomach, CT would have allowed, a CT-based algorithm would have allowed esophagectomy in 19 patients and gastrectomy in 13 patients when compared to endoscopy-based algorithm. We made a univariate analysis for transmural necrosis, And we saw that severe oropharyngeal injuries, blood lactates, liver blood tests, and thrombocytopenia could help decide whether you should operate or not these patients, whether they have or not transmural necrosis. Just to show you that patients who had conservative management had sometimes complicated courses, mostly pneumonia, and some of them even required tracheotomy. But again, the wait-and-see mortality was nil. Now you'll tell me that I'm coming from a high-level center, and can these results be exported elsewhere? So what we did, we asked 3 radiologists, 1 gastrointestinal senior, 1 general senior, and 1 resident who are blinded to patient's outcome and to the pathological results to read the CT scans, and actually the inter-observer agreement rates were quite high, so I think it can be done elsewhere than in our center. So the answer is yes. I think that we can use only CT for to manage these patients, and when you have necrosis, you do what the CT says. For the stomach, it's simple. If you have a doubt, you perform laparotomy, and I'll come back on it. If you have a doubt on the esophagus, I think you should see the stomach, because you see there are difficult situations. Like this, you have an esophagus, you don't know very well what happens, you see the stomach, it's okay. Actually, in our experience, we had never had 1 patient with isolated esophageal necrosis. So if you have a doubt on the esophagus and the stomach is okay, I think you should wait. On the other side, if you have a doubt on the stomach, you don't know very well, that's simple, you go and see. And just to show you that CT scan can do even more, this patient had esophageal necrosis, gastric necrosis, duodenal necrosis, you see it very well, and even small bowel necrosis, while this one did not have esophageal necrosis, but had gastric necrosis, duodenal necrosis, and bowel necrosis. So I think that CT scan shows us everything we need to know. Thank you very much for your attention.